This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and today we're stepping slightly outside the traditional operating theater to look at how we manage the polytrauma patients we often see on the neurosurgical service.
And I'm Dr. Alera. Today we're looking at a fascinating new study from Emergency Medicine Australia, published in 2026. The paper is titled Developing and Designing an Evidence-Informed Serratus Anterior Plain Block Education Program for Emergency Medicine. While the primary focus is emergency care, as neurosurgeons, we frequently manage patients with concomitant rib fractures and spinal trauma. So understanding the standardization of regional anesthesia, like the SAPB, is crucial for our procedural armamentarium.
Exactly, Alara. We'd often focus on the intracranial or spinal pathology, but the patient's respiratory effort and pain management significantly impact their recovery. The Serratus Anterior Plain Block, or SAPB, is an ultrasound-guided regional anesthesia technique that provides analgesia to most of the chest wall. The study notes it's being used as an analgesic adjunct for rib fracture-associated pain.
It's quite impressive. The paper highlights that a single depot infiltration of local anesthetic, what they call a single shot block, leads to an early, significant reduction in pain scores and a marked reduction in opiate consumption. It's described as feasible and quick to perform in the emergency department setting.
But the problem, as the authors, Partika and colleagues point out, is that because it's a relatively new procedure in this field, it isn't taught in a formal manner. It's often just local clinical leads upskilling their colleagues in a non-standardized way. So they set out to create an open-access, shareable educational program built on solid educational theory.
To do that, they used Kern's 6-step approach to curriculum development. For our residents listening, Kern's framework is a gold standard in medical education. It starts with problem identification and a general needs assessment, moves through targeted needs assessment, goals and objectives, educational strategies, and ends with implementation and evaluation.
The authors mentioned that steps 1 and 2, identifying the need, were already established by the growing evidence of SAPB's efficacy. This paper specifically focuses on the development phase, steps 3 and 4. They broke their process into 3 distinct parts. Ilara, do you want to walk us through part 1?
Certainly. Part 1 was about developing expert consensus for education, training, and credentialing. Since there are no universal standards for when a clinician is ready to perform an SAPB independently, they used a modified Delphi study.
I saw that. They recruited 30 expert clinicians from Australia and Aotearoa, New Zealand, including specialists from both anesthesia and emergency medicine. Why is the Delphi approach so important here?
Because it allows for a structured consensus. They did 3 online rounds of questionnaires. The experts had to agree on 3 key components: theoretical knowledge, the training process itself, and finally, the requirements for credentialing. It ensures the curriculum isn't just one person's opinion, but a cross-specialty agreement on what constitutes competence.
And once they had that consensus, part 2 of the study moved into the actual pedagogical design. This is where it gets very interesting for those of us involved in resident training. They didn't just throw a PowerPoint together. They used frameworks like Bloom's taxonomy of educational objectives.
Right, and they combined that with backwards design and constructive alignment. In backwards design, you start with the end goal, what the clinician needs to be able to do at the bedside, and work your way back to the teaching materials. They also emphasized scaffolded learning and segmented learning.
Let's dive deeper into those pedagogical terms. Segmented learning is particularly relevant for busy surgical residents. It involves breaking down complex procedures into manageable chunks. For an SAPB, that might mean separating the ultrasound anatomy of the thoracic wall from the needle handling techniques.
And the scaffolded learning ensures that the learner builds on prior knowledge. The study describes the program as an educational tool for clinicians who are already proficient in the general principles of plain blocks. It's not starting from zero. It's adding a specific evidence-based skill to an existing foundation.
It's about constructive alignment, ensuring the learning activities actually match the intended outcomes. If the goal is to perform a safe ultrasound-guided block, the education must involve practical workshops and supervision, not just reading a paper. The authors even provide guidance on establishing local workshops for that practical education.
That brings us to part 3 of their method, alignment with national policies. They made sure the program aligned with existing national standards for regional anesthesia in the emergency department. This is key for governance. They aren't trying to reinvent the wheel, but rather ensure the SAPB fits into the broader safety and supervision frameworks already in place.
The result of all this is an evidence-informed SAPB education package. It's supported by the most current evidence for using the block in patients with rib fracture pain.
One of the takeaways for our listeners is how this framework provides a template for introducing any new clinical procedure into routine practice.
Exactly. Whether it's a new bedside drain technique or a specific regional block, the study argues that we need a balanced combination of clinical science, procedural expertise, and educational theory. The goal is to rapidly upskill a large number of clinicians in a standardized manner.
In the neurosurgical context, we see many patients with multiple injuries. If our EM colleagues or our own residents can provide effective regional anesthesia early, reducing the need for systemic opiates, we may see fewer complications like respiratory depression or delirium, which can cloud our neurological assessments.
And the study emphasizes that this isn't just about the how-to of the needle. It covers ongoing supervision and governance. They've really looked at the long-term sustainability of the skill, not just the initial workshop.
It's a rigorous approach to something that is often left to see one, do one, teach one. By using a modified Delphi process and pedagogical frameworks like Bloom's, they've turned a procedural skill into a formal curriculum.
It really highlights that being an expert clinician doesn't automatically make one an expert educator. Designing these programs requires a specific methodology to ensure that the theoretical knowledge and procedural expertise are actually transferred to the trainee effectively.
Well, that's about all the time we have for today. This study is a great reminder of the intersection between clinical excellence and educational theory. If you're looking to implement an SAPB program in your department, this 2026 paper in Emergency Medicine Australia is the blueprint.
Thanks for joining us. I'm Dr. Alera.
And I'm Dr. Aris. We'll see you next time on the Neurosurgery Hub podcast.